has really challenged us to think about how AHRQ can better position ourselves to better serve our customer needs and to think about the ways we are doing our work as we think about the greater world and how we are moving towards greater digitization all over. And we have been employing a number of challenges. Many of you may have heard about some of our other work. You can visit our website to see more of the challenges we're doing. And we're really excited about using this mechanism and really leveraging our public-private partnerships to help us think through this next phase. And so with that, I'm going to turn it over to my colleague, Celeste Torrio, who's been instrumental in helping lead this effort, and she will help guide us through the specifics of this challenge. Thank you.
Thank you, Jamie, for the introduction. Welcome, everyone, to the Bringing Predictive Analytics to Healthcare Challenge webinar. We are pleased that you all can join us. Next slide, please. Today's agenda, we will go over the purpose of this challenge, the timeline and prize structure, the submission, the review criteria, the submission process. And we will also highlight our 3 themes for this challenge. And these include healthcare utilization, the data, and predictive analytics. We will wrap up our webinar with the Q&A, and we will try to answer all of your questions during that time. Please keep in mind that any questions that we are unable to answer during our webinar will be answered shortly and posted on our website. Next slide, please. So our challenge purpose, just to give you a bit of background, traditional approaches in health services research rely on rigorous methods, the availability of recent data, and peer review to assure the highest quality of analyses. However, some decision makers must make policy decisions quickly with the current information available and cannot wait until new analyses are complete. The predictive analytics and related methods may offer a solution to balance the need for rapid information and academic rigor. While predictive analytics and related methods have been used successfully in many fields, their use to understand how healthcare is delivered is largely unexplored. So AHRQ's purpose is to explore how predictive analytics can be applied to existing databases to forecast the future use of healthcare resources, to generate information, and contribute to a greater understanding of healthcare issues for policymakers, healthcare delivery system leaders, providers, researchers, and other stakeholders to make public and private healthcare decisions at the local level. AHRQ encourages participants to apply independently or team with others, including health IT developers, healthcare providers, and other entities with appropriate expertise to apply predictive analytics and related methods using AHRQ's current data infrastructure to estimate hospital inpatient hospitalization. Next slide, please. So the total prize pool for this challenge competition is $225,000. The winner of the first prize receives $100,000. The submission deadline is on June 28th at 5 p.m. And we expect to announce the winners for this competition on July 31st. Next slide, please. So for submission requirements, applicants must submit 2 files that have a total of 3 items. The first file contains items 1 and 2, while the second file contains items 3. These files must be submitted again by 5 p.m. on June 28th. So what exactly are these items in file 1? Well, the first item involves predicted values of the total number of hospital inpatient discharges and the mean length of stay for selected counties in the U.S. for the year 2017. We are specifically asking participants to create models that estimate hospital inpatient hospitalization for 2017. For item 2, we are specifically asking participants to test their models by submitting predicted values for the number of hospital inpatient discharges and the mean length of stay for selected counties in the U.S. for 2016 by applying the model methods and analytic approach used to obtain the 2017 estimate. Item 3, which is in the second file, includes a brief report that describes the model methods and analytic approach used so that the predicted values may be replicated. Because AHRQ will be providing temporary access to customized analytic files that include information on hospital inpatient discharges for years 2011 through 2016, It's really important that participants submit a data use agreement. And additionally, participants may supplement their access to AHRQ data at their option by using free publicly available data sources. Next slide, please. So we will score your submission using 2 criteria, and that's reliability and validity. So in general, reliability is assessed by how closely the model predicts the actual utilization rates for 2017, while validity will be assessed by how well the model performs on earlier years of data. Please note that you will be provided with an Excel spreadsheet that includes columns where the predicted values are to be inserted, and you will return it to AHRQ. For counties where 2017 data are available, to AHRQ by June 28th. An overall evaluation metric will be calculated. To find out more about the overall evaluation metric and how it's calculated, please go to our challenge website and click on the tab for evaluation criteria for more detail. Next slide, please. As mentioned in the previous slide, because AHRQ will be providing temporary access to customized analytic files, you must sign and submit this AHRQ Bringing Predictive Analytics to Healthcare Challenge Data Use Agreement, which you can access on our website. It's imperative that your access to and use of the AHRQ data files that are made available for the purpose of this challenge be consistent with the terms and conditions of this challenge. If you do not sign and submit this data use agreement, your submission will not be eligible to win this challenge. So I want to emphasize that the data use agreement is an extremely important submission requirement because you will not be able to access the customized data file unless you sign and submit it. This data file is part of the submission material for providing predictive estimates for the challenge and must be uploaded. Next slide, please. So participants can register on the challenge website. The registration page will ask about your personal information, contact information, and information about your eligibility for participating in this challenge as indicated on the eligibility rules. And for more detail about the eligibility criteria, we ask that you go on our website where there's an eligibility criteria tab. Next slide, please. During the submission process, we want to make sure that you completely understand the submission requirements, the review criteria, and the eligibility requirements for this challenge. Next slide, please. And after you register, you will then be prompted to review your registration information prior to submitting your application. Next slide. And after reviewing your information and clicking on the Submit button, please be sure to upload your files by clicking on the Documents tab. Next slide. And to upload your files, please click on the Add Document tab. Once you have uploaded all the required documents, you will have completed the submission of your application. So it's an easy submission process. Next slide, please. So now that we provided you with an overview of the challenge and submission requirements, I'm happy to introduce to you our experts for our challenge theme on healthcare utilization. And they are Drs. Rob Saunders and Norma Padron. Dr. Saunders is a research director for payment and delivery reform at the Duke Margolis Center for Health Policy, where he leads specific projects in digital health technologies, evaluation of new payment policies, and federal physician payment reforms. Dr. Padron is Senior Director of Applied Research and Data Analytics at the American Hospital Association, where she oversees a shared services unit with a mixture of data reporting and IT services. I now turn it over to you, Dr. Saunders.
Thanks, Celeste. As mentioned, I'm Rob Saunders. I'm with Duke University. And if we go to the next slide, my job today is to give a bit more background on why this is important, maybe a little bit more on the context of why folks are interested in healthcare utilization and some of the applications that we're starting to see today for this type of predictive analytics for utilization. So just to level set, if we're having a challenge talking about healthcare utilization, it's important to define what that is. At a broad level, healthcare utilization is, any time that a person interacts or touches the healthcare system. So when you go to visit your primary care clinician or go to the hospital or go to the emergency room, all those are examples of healthcare utilization. For this challenge, we're limiting ourselves to inpatient stays in hospitals, and we're doing that because for a few different reasons, but one big reason is that there's still a big chunk of the healthcare dollar, somewhere around 35 or 40%, that goes toward those types of hospital uses. So clearly this is an important issue. There's also another big reason to focus on this. Hospitalizations have been sort of widely tracked across the U.S. For a few different reasons. One is that they're relatively easy to measure. So a lot of healthcare measurement today uses administrative data, or if you're a healthcare policy wonk, you'll say claims data. And healthcare hospitalizations are relatively easily findable in that, whereas a lot of more advanced measures require more advanced data sets that maybe you can't get. So hospitalizations have been used a lot to give us a sense of how we're doing. If we go to the next slide, another big reason to look at healthcare utilization is just because we're changing how we're paying for healthcare nowadays. So there's new payment models out there, and each of those involve different types of measures for cost and quality. You'd think that would be simple to measure, but it turns out both of those are pretty complex. In terms of cost, it can be really difficult to figure out what prices of things are in advance because those are often done from negotiations between health insurers and, say, health systems. And so utilization gives you a way to get a sense of what costs are probably like, even if you can't get to that underlying price. And for quality, again, it can be really difficult to figure out quality given the data that we have available to now. But oftentimes, you can use this type of utilization data to get a sense of at least some unwanted or maybe unhelpful or unnecessary utilization. So, for instance, if you have a really sick population, say folks that are really seriously ill, and they're ending up in the emergency room and the hospital a lot, that can be a good marker to say maybe these folks aren't well managed and we should be doing something differently. So for those reasons, you see this type of utilization data nowadays being used a lot in terms of measuring cost and quality. And, hospitals are being held accountable for a lot of those cost and quality measures. And so they're very interested right now in figuring out how do they predict who's using their services and who they're responsible for, and therefore be able to do a better job of maintaining those folks' health over the long terms. So if we go to the next slide, let's talk a little bit about some of the context we're seeing some of these predictive analytics used in. So at the individual patient level, as I mentioned earlier, hospitals and other health systems are really interested in figuring out who is going to be using healthcare services in the future and how do we make sure we stabilize those folks so that we're able to take better care of them, especially in light of these new payment reforms, which mean the hospital or the health system are held accountable for their overall health of their population. So, most healthcare today is pretty reactive. We only sort of know when somebody's not doing well after they've been, having a few cycles in the hospital or in the emergency room. So the hope would be if we could catch folks earlier, we could treat people, keep them at home, keep them healthier as best we can. At a broader level, the ability to understand hospitalization rates and healthcare utilization writ large also gives you a sense of what's going on in that local community or that local geographic area, because there's a lot of factors that affect whether people are using the hospital. So, for instance, on a very simple level, you could say you can see folks that are in the hospital a lot more because maybe they have housing insecurity. They don't have stable housing. So if they're diabetic, it's very hard to be discharged because they don't have a place to store their insulin, or they don't have a place where they know where they're going to get their next meal. And so the only place they can stay stable is in the hospital. That's information that is helpful for a health system to know and for even a broader government, a local government, a state government to know if they're thinking about sort of the health of a broader population. So I hope I gave you some sense of context and why healthcare utilization is important, why folks are thinking about it nowadays in terms of new payment reforms and the like, and also where we're seeing some predictive analytics, both at the individual level and at a community and regional level. And now if we move to the next slide, I'm going to turn things over to Norma, who's going to go into a bit more depth.
Hi, everyone. Very happy to be part of this, and thank you, Rob. I think that you provided very interesting perspective on why healthcare utilization is such an important aspect for this challenge. And so one of the questions that we were asked to think about was to bring a little bit of perspective on how does healthcare utilization can factor into care and hospital management. And so one big area right now that I'm pretty confident most people have come across is this term of population health. And so when thinking about understanding healthcare utilization, and particularly for this challenge, which will be measured as hospitalizations, this can really help health systems and hospitals and local public health departments and administrators to think about a broader view and perspective of how individuals have a journey in and out of the health system. And so part of the work that I do with my team at the American Hospital Association and through the Center of Health Innovation is designing methodology and really assisting hospitals around the country on understanding how to better design services for their patients. And so I really feel very strongly that when we investigate healthcare utilization, so say volume that is experienced by hospitals in any specific region, be it a county or metropolitan service area, it can really improve how the service lines are designed. So how the services for cardiology or cancer or specialized services are designed. And so another question that was asked as we were sort of invited to provide a little bit of perspective and context on the very important role that accuracy in predicting hospitalizations can play in healthcare services. So the other aspect in which accuracy in predicting hospitalizations can be very valuable is in this concept of regionalization of care. And so particularly in parts of the country where there is either low population density, or areas that are rural or where access is difficult for patients, there is really, I think, particularly from the academic literature and hospitals coming together, efforts around a concept called regionalization of care. And so you can imagine that, for trauma care, or for heart disease, or for highly specialized services in oncology, you truly want to ensure that appropriate access is available for patients, but sometimes it's limited. The physicians in the area, the number of physicians in the area, or just the physical infrastructure for having those hospitals. And so if we were truly able to have highly accurate models of predicting hospitalizations in counties, and again, in regions, then we can move a little bit more towards the identifying if and how regionalization of care can be optimally designed. Next slide, please. So one of the other aspects that I sort of wanted to provide a little bit of context or perspective is that part of the data set that you'll have access to through AHRQ does have categories of visits for hospitalizations. And so I think that though it's not necessarily part of the challenge, because the challenge is broader, as you investigate the data, as you explore the data, I think I would really invite you to think about, for instance, examples like this one right here, where you start understanding emergency department utilizations by age bracket, and you can ask yourself questions like, for a given county or region, what will be the rate of emergency department visits? And then given a county demographic and social characteristics, what will be the age group that will experience the largest increase emergency department rates? And I think that this is just clearly just an example. Your challenge is broader than this, but I wanted just to underscore that accuracy and accurate predictive models for hospitalization can be incredibly powerful for really providing better access to patients across the country. Next slide, please. And so my last comment to bring a little bit of perspective is that as it was mentioned by Celeste in the introduction, I do work with data from hospitals around the country, and my team and I provide data products for decision support systems and for, chief clinical officers, et cetera. And one of the things that I found incredibly useful and readily available and accessible is looking through data that can bring more context to just the clinical and quality data that I generally work with. And there is an incredible amount of wealth of data out there that I just wanted to underscore for you. And so here's just one example from Philadelphia that I really like, where the city produced this Philadelphia Community Health Explorer. And so as you're aware, really a variety of fields of study and disciplines are coming to the consensus that social and economic factors really play a huge role in outcomes and health status. And so this particular explorer actually brings together data from social and economic factors in health of the city. So I will invite you to sort of explore this type of available data. You can also download that data. Similarly, counties and states across the country, particularly from 2010 onward, have been moving pretty heavily in their efforts around open data. And so I think that I would really invite you to just kind of really explore that data. So here are two examples, one from the County of LA, the other one is a specific health data sets for health from the state of New York that I would truly invite you to explore. And similarly, there are academics and researchers very consistently use data from nationally representative data sets, which I think could be very helpful for the work that you're going to be conducting. So just wanted to make you aware, there's the iPhones data from the University of Michigan, there's the panel study of income dynamics, the National Health and Nutrition Examination Survey, Health and Retirement Study, and of course statistics from the National Center for Health Statistics. And then just the last few thoughts that I'm going to leave you with is that it definitely will be, it won't hurt your efforts as you go through this challenge to review some of the available literature. I was just cursory browsing the literature, and I was able to find models from like the 70s and 80s, Markov models trying to predict hospitalizations. And so there's a lot of information out there, and so this is a very timely challenge. We're very interested in the healthcare space to have better and accurate predictive models for hospitalizations, but I would definitely recommend you to take a look at these models using system science and some models methodologies that might help your thinking around the challenge. And with that, Jamie, you can go to the next slide and introduce the next speaker.
Hi, Celeste, hi, Herb, are you on?
Yes, I am. So sorry about that. So my name is Herb Wong, and I am the Senior Economist with the Agency for Healthcare Research and Quality. In this segment of the webinar, I'm going to describe to you the customized data file that AHRQ will provide to you as challenge participants. In addition, I'm going to give you kind of a thumbnail sketch of what you should submit to AHRQ for consideration for the prize awards. Next slide, please. So the customized data file that AHRQ will provide to challenge participants is a county-level file. So in other words, the unit of observation is at the county. You will get 6 years of data in this particular file. participants will receive data for years 2011 through 2016. For each year, there's going to be 5 data elements. You're going to get the state abbreviation, the county name, the fifth state county code, and the number of discharges associated with those counties, as well as the average length of stay, again, associated with those counties. The data file that we're going to be providing to you are complete in the sense that all 6 years of the time period has all the counties that populate all those fields. So in other words, you're going to have roughly 2,173 counties in this file. Next slide, please. So to understand how this file is constructed, challenge participants are really encouraged to go to the AHRQ Healthcare Cost and Utilization Project, or HCUP website. You should click on a link there that is called HCUP.net. Now, HCUP.net is our online query system that provides aggregated information based on HCUP databases. Participants should really focus on community-level statistics. The customized file that we will be providing to participants really follow the same methodological approach as those statistics generated on the HCUP.net website. There are a good number of helpful documents on the website that challenge participants are really encouraged to become familiar with so that they can understand the data source. The one document that I would encourage participants to really review is entitled Calculating Community Level Statistics for HCUP. That document is pretty comprehensive, and it tells you how those statistics are in fact created at the county level. The other component that challenge participants are encouraged to do is to supplement the AHRQ customized data file with other outside data sources. There are 2 requirements for the other data sources that you can use for this particular challenge. The data source first must be publicly available, and second, it must be free of charge. So proprietary data that involves any sort of fee are not permitted. Next slide, please. So by June 28, 2019, as Celeste mentioned a little bit earlier, challenge participants are asked to provide the following information to AHRQ if you want to be considered for a prize award. First, we're asking you to provide us a data file with the following data elements: the fifth state county code, the 2017 prediction of the number of discharges associated with that county, the 2017 prediction of the average length of stay associated with that county. Now, the 2017 predictions are the most important elements of this particular challenge. So I encourage you to focus on getting the 2017 predictions as accurately as possible. Now, in addition, we are also asking you to provide us with your predictions for 2016. That is the 2016 prediction for the number of discharges and the 2016 prediction for the average length of stay. These 2016 predictions must be based on the same methods that you use to come up with your 2017 predictions. So in total, we're looking for you to submit a data file to us that will have 2,173 observations. And there are going to be 5 data elements associated with that. Again, they're listed on the slide here. Next slide, please. So in addition, we're asking challenge participants to submit a brief report to AHRQ. The report must contain sufficient information for AHRQ to basically replicate your work and your predictions. So for example, it should provide enough detail that if AHRQ were to start completely from scratch, we can search out, obtain all the supplemental data files that you deployed, use your methods, and we should get exactly the same results that you provided to us in that file I talked a little bit about earlier. In general, the report should have a description of the model or the algorithm that you deployed. There should be some explanation of your basic assumptions in building your model or the logic behind the model that you deployed. If you could provide us with your actual programming language or the actual code itself, that will help facilitate our review of your application. If you have a description of a publicly available database that you use, the more detail that you can provide to us, the better. Again, the report should have enough information for us to replicate your work. With that, this kind of ends my segment of the webinar, and I will turn that over to, I guess, Celeste to introduce our next speakers.
So now that we provided you with an overview of the challenge for the healthcare challenge for healthcare utilization and the data, I will now introduce you to, to Dr. Jonathan Weiner and Mr. Charles Gabriel. Dr. Jonathan Weiner is the Professor of Health Policy and Management and Health Informatics at the Johns Hopkins University, and he is a national leader in research, development, and training regarding population-level predictive modeling and analytics. Charles Gabriel is an analytics and data science manager with 25 years of experience in data science and analytics in many sectors and elite organizations such as IBM, the World Bank, Deloitte, Discovery, Humana, and the Center for Medicare and Medicaid Services, and the Defense Health Agency. They will be focusing on the challenge theme of predictive analytics. I turn it now to you, Dr. Weiner.
Thank you, Celeste. This is Jonathan Weiner. I'm really pleased to be here today. This is an exciting event, part of a broader trend in healthcare and sort of a blending of science and analytics and business, and I'm pleased to be part of this. Our section for the next 20 minutes is I will begin to discuss some of the frameworks, paradigms, approaches that others have used, but you're all innovators, so you'll probably use somewhat different approaches, but others have used in predictive analytics, or sometimes called data mining or machine learning. And Charles, who's very experienced, will bring it the next step to make some suggestions about actual sources and approaches that he might recommend. First of all, there is no consensus what is predictive modeling. There's over 100 of you on this webinar, and you each have perhaps a different preconceived notion to what even the term, what's predictive modeling, what's data modeling, data mining, what's machine learning, and that's fine because there is no one right approach. You might look at the data you're being provided, and it's really fairly straightforward, but deceptively so. There's an awful lot that goes into with the excellent presentations that Dr. Saunders and Padron. You appreciate that how complicated our healthcare system is and utilization. By the way, teams made up of people knowledgeable on healthcare, knowledgeable, frankly, on population health and social demographics and social determinants, because after all, we're not dealing at the individual level. You're dealing at sort of a community level. And, of course, analysts. Those analysts may come from a background of statistics, business. You may look at it and say, well, this is a simple trend analysis moving forward and forecasting. Well, not so simple, because healthcare really varies by location. So I believe the successful team will partner both knowledge of healthcare, knowledge of the analytics, and there are controversies out there of the best analytics, and frankly, this will be empirical. So may the best person win in terms of the skill set. And historically, the difference between some of the econometrics or statistics or business analytics and the so-called newer, deep learning, machine learning, data mining isn't as great as you might think. But a blending of the approaches might be the best approach. So again, but an understanding of both the statistics and both the factors and both the context. Next slide, please. I've tried to lay out, again, I'm involved both in preparing population-level, community-level predictive models for tools around that we develop at Johns Hopkins around the world, but I'm also involved in teaching and trying to develop concepts and frameworks. And I'm excited that some of you will help move the field forward. And again, kudos to AHRQ and other sister federal agencies for trying to support innovation in this domain. But if we look at the full domain of going from big data, digital data, raw data, to the digital modeling process, step one has already been done for you to some extent. So it was not easy to pull together the HCUP, that is the hospital utilization data that AHRQ develops with collaboration from other state agencies, but that's been done for you. And learning more about it and where it came from will be important. A lot of steps went into preparing that data, and the more you can learn about its strengths and weaknesses, Herb suggested how you can do that, the better it'll be. The predictive modeling that I and Charles are talking about in this module, there are many different ways to do it, but basically looking at the top right there, 3, it's using base year, in this case, several base years to predict, in this case, the outgoing year, I guess it's 17, but in fact, you're going to have to test that, model it, and that's where step 4 comes in, develop validation, evaluate, try alternative models using statistical approaches, different data sources, trying to see if you can get the best fit for the model. Now, ultimately, this horse race, this grand challenge is about strutting your stuff and showing that you can develop a good model, but the end game isn't really just about that. It's about all of us trying to develop new knowledge. That's AHRQ is an agency of science and knowledge. Can we learn? Can we ultimately improve healthcare, and then ultimately change the feedback loop? Again, your responsibilities will be 3 and 4, but obviously the bigger game involves 1 and 2 and 5 and 6. Next slide, please. To give you a little more practical guidance, next slide, please. There's no right way to do the predictive modeling. I would recommend, all of the speakers have suggested, and I will on my last slide, suggest some resources that you can use to learn. And there is no right way, but it's always good to, what do they say, stand on the shoulders of those that have come before. And there have been a lot, particularly lately, individuals both out of the epidemiologic and biostatistics school, and now increasingly computer science and other approaches, and see what they have done. And you'll find there's a whole bunch of alternative approaches. However, there are some standard kind of contexts, a few of which I'll share with you here, and Charles will continue that in a few minutes. What is the purpose, the use case, the context? That was given to you. What is the denominator? In this case, that too was given to you, the counties for which there are data available, which is most American counties. Normally, the time frame can be complicated. Here, the time frame was given to you. But don't forget, you will probably be testing various time frames. The ultimate answer, I believe, is for 2017, but you won't know that answer. On the other hand, you will know the answer for earlier years, so you're going to want to test, retest, develop the model, figure out the denominator, see where you do well, where you do poorly. It could be that rural states are a problem for you. As far as I know, there's equal rating across all, rural counties I meant to say. There's probably equal weighting. So you need to maybe fine-tune and understand where is your model better or weaker. And it could be the size of the county. Could be things happening. So clearly you're going to need, the team that wins, I predict, is not only going to be good in the modeling, in the data, in the statistics, but also in understanding the factors, understanding the context. As I've already alluded to the bottom of the slide here, usually this is done with sort of a split half or a reserved half, where you take and you develop the model with a group of people and you test it on a different group. This is a little different. You can do that. You could split the counties randomly and test it with one half, develop it on one half rather, and then test it on another half. But what really is going on here is you're going to sort of test it and develop it on 16, and that's one reason I believe that you're providing it. And again, the goal is to show that it can be reproduced by anybody. And then the ultimate test will be for 17. So I would encourage you to look at it carefully, and I'm going sort of quickly, and I'd have to study it more carefully. But the main point is that you test, retest, You try different approaches, you try different statistical approaches, data mining approaches, and you fine-tune it, as you would any sort of product, any sort of analysis. Next slide, please. And what is a good predictive model? You want it to be as simple as possible. If this were to actually be used, you want it to less moving parts, the better. You want it to fit. You want it to, the truth matches your prediction. Because this is part of a broader framework, and because you can't just pull a number out of a hat or in theory find the numbers elsewhere, you have to show that it's consistent, that it makes sense, that others can use it, particularly in the real world. That is sometimes a controversy between using complex data mining, machine learning, versus a more standardized clinical or economic. And the reproducibility, this has to be used elsewhere. Next slide. This is my last slide, and I, like the other authors, presenters, tried to offer you various papers that have been done or monographs. In this case, I suggest a few both from the health policy, health services research domain, and also more recently from the machine learning, mainly in medicine. There also, to plug another HHS unit, the Office of the National Coordinator supported a group of academics to develop freeware, various presentations in various domains of health IT, and there are several that I suggest here that might be helpful here. I'll pass it over to my colleague Charles, and good luck with the activity, and I hope this sets you up well for a future work in healthcare data mining and forecasting in this space. Thank you. Over to you, Charles.
Hi, everyone. It seems we're having some technical difficulties with Charles's microphone. We're just going to work those out. We're going to take a brief pause and work out his the technical difficulties, and we'll be right back online.
This is Jonathan Weiner, if you can hear me. Organizers, if you'd like me to fill in, I can, but hopefully Charles can come online, so your decision.
So thank you, Jonathan. I think what we're going to do is take a couple questions while we sort out the technical difficulties. We do have some queued up. So Celeste?
Sure, yeah. I have a question. Did you want me to read them?
Sure. Yeah. We've sorted out some of them. I think you can go through the ones that we've queued up already.
Okay. So this question is actually for Herb. Where do you go to get the data in Table 1 in the Calculating Community Level Statistics for AHRQ Methods document?
Sure, I understood that.
Okay, I'll read it again.
Yep.
Where do you go to get the data in Table 1 in the Calculating Community Level Statistics for AHRQ Methods?
So if you go on the AHRQ.net website, if you type in AHRQ.net, HCUP.net, and search under Community Statistics, there is a document there that will describe that. In addition to that, I think what we can do to make it easily available to folks is to put it on our website after the call. So it might be a little bit cumbersome for some folks, but let us put that document in an easily reachable place for folks.
Okay, great, thank you. We have another question. If part of an organization should the data use agreement be executed by each team member or the organization or both?
The execution of the data use agreement is for that one individual that represents that organization. So we don't need to have, if there are a team of, say, 5 or 6 people in the organization that is participating in that, the person who basically registered on our website, signed a data use agreement, we will hold that person responsible for the conclusion and destruction of the data after the challenge. So only one person needs to sign it.
Can you hear me now? Hello?
Yeah. Hi, Charles,
okay.
Is that you?
Yeah, that's me.
Great.
Okay, so sorry about that. I unmuted myself on that computer, but it didn't work out.
No worries. Thank you.
Should I start now?
Yes, I think you can, and then we'll handle the rest of the questions during the Q&A part, which is just after your section. Thanks.
All right, so I'm going to go over quickly, practically speaking, how would you build a predictive model, successful predictive model for healthcare. So if you think about predictive model in a practical way, it has 2 components. You probably, one component, as you know, is to uncover a hidden pattern found in historical and transactional data to predict a relationship to a risk or opportunity outcomes. So that's, in a nutshell, what I would kind of draw to myself when I build a predictive model. So if you look at those 2 pillars, try to put them in a set of processes or activities to develop a useful predictive model. The first one is to think about is to understand the problem space. And when I mean by the problem space, understand how hospital works from a high-level perspective. The workflow, especially in what happens when hospital discharges a patient. They normally discharge a patient with some instruction, if there is some specific cases, for them to follow up on those instructions and help them recover through the course. Also, sometimes they discharge patients to go to a nursing facility. So keep that in mind as you understand the problem space. The second piece is try to bring more variables to enrich your data set that you have. And one example for that would be a demographic, location, socioeconomic data. As you integrate this data, the third step is to try to understand why you are bringing this variable. You are bringing those variables to uncover hidden patterns. So demographic, for example, age, you can think about normally an older age would be a prone for high risk for readmission, of course. Location, whether it's a rural area or area that doesn't have access to care, would be a factor for such outcome. Socioeconomic, employment, income, education would be another variables. Think about the education as a factor to read the instructions or follow the instruction as you get discharged from the hospital. By now, you have some kind of a confidence that there is a pattern across the data set that kind of compel you to establish now a relationship between or a correlation between the variables and the risk outcome, which is in this case the readmission. So lower readmission rate or high readmission rate would absolutely be interpreted by the factor that I just mentioned or by the pattern that you already discovered in the previous step. Next slide. So these are set of data that exactly will help you enrich your data and add more layers of data that will help you in your prediction and discover the hidden pattern and also establish the correlation with the risk outcomes. You will see some example of readmission processes in California. You will see some hospital location data set that may help you join the county level from the data set that you are given from AHRQ with this data set. This way you can have more maybe hospital variables in your data set and so far and so on, and you have some demographic data. These are examples just to help you to start, but by all means you can research and find from Center for Medicare and Medicaid some more data set if you choose to, and to help you with your predictive model and add more logic, more sense to your data. Next slide. And again, as many of the speakers said, and one model will not be able to help you build a predictive model. At least 2 or 3 predictive model will give you more confidence and more high probability with what you are trying to do, and especially when you try to do pattern discovery and aggregate the data or summarize the data in the beginning to get sense of how the data is structured and so far and so on. So the first link is we'll show you a couple of those models that you can use or you can research if that's your first time. And those softwares that I'm putting here, you can download them for free. Some of them are open source, very well known. The R is an open source, but Microsoft Power BI is very solid tool. You can download it for free, and I would encourage you to use it. It has a very nice visualization capability, as well as a lot of machine learning and predictive model algorithm. And SQL Server Express is kind of a desktop database in case if you want to put those data in a database and query this database later on. I hope that would help, and happy to answer any questions, or if you want to challenge any of the content, I'm happy to defend it as well. So good luck, and thanks for AHRQ for this invitation.
Thank you, Charles. So we're now going to open up for questions again. On your screen, you should see a panel where you can submit your questions. I think a number of you do this. So if you're on the queue, Jen will take your questions. Thanks.
Hi, Celeste. We have another question. Looks like this one would be for Herb. What does AHRQ plan to do with the end products from this challenge? Do you foresee future studies, grants, and contracts on this topic from AHRQ?
So AHRQ is interested in the predictive analytics space in general. And our intent is to kind of understand what the current science is out there in the world, especially as it applies to healthcare data, particularly the data sets that AHRQ has, such as HCUP, MEPS, and others. We want to understand how we can move into a space of predictive analytics and to forge new programs in the future.
Thank you, Herb. Now we have another question. It looks like it would be appropriate for either Dr. Weiner or Dr. Gabriel. In the expert's opinion, should contestants focus on finding novel variables versus a novel algorithm? In my opinion, the winner of this competition will most likely have a better variables versus a better algorithm.
May I answer this question, Dr. Weiner? You can comment. Okay, so it's in my humble opinion, I think it's about the prediction, is not about the algorithm. It's focus on the product, meaning how would you, with high accuracy, how would you predict the outcomes? And especially if you incorporate a lot of health determinants and health factors in your model and in your assumption, that will give AHRQ leverage to understand how the model is built, not necessarily from algorithm perspective, but from a process, from a data, from an outcome perspective.
I mean, I tend to agree, if you can hear me. And so I think it's a blending of both, but I think it's mainly going beyond the data that AHRQ provides. Moreover, don't forget, you will be able to, now the rating, the winner, will be pretty much entirely empirical. So in that case, you know, the model does have to be the best predictor. In other contexts, sometimes it includes what you can do with it, which Charles is hinting at. In addition, don't forget, you can test the model by using earlier years to predict 16 or 15. So you'll have a pretty good sense of how well your model does. You can answer your own question.
Thank you. We have another question. It looks like it would probably be for Herb. Can we use proprietary tools like SAS to create models? Yes. Or the tools have to be open sourced only?
You can, tools such as SAS, Stata, software that you need to purchase is okay. It's appropriate to use those statistical programs to come up with your predictions and your modeling.
Okay. Are any predictors not allowed, such as those that may discriminate by race, age, gender?
Any explanatory variable that you feel is appropriate for the purposes of predicting discharges and average length of stay is fair game.
Okay. Is interoperability, explainability a consideration, or can the model be black box like the complexity, like in complexity? Sorry.
The way in which the information, the methods that you deploy have to be replicable to AHRQ. So we have to have a sufficient amount of information that if we were to start from scratch, we can replicate everything that you have done. That means collecting the other data sources that you've had, deploying your methods using whatever program you have, and getting the same predictive value. If it's in a black box, unless the black box is free to the world, that's the only situation I could think of. So.
Thank you. Is the submission judged solely on metrics, or is there anything else to take into consideration?
As Jonathan mentioned, the we asked for basically two components. The first component is the brief report. The brief report is designed for us to replicate what you have done and for face validity. Once it passes that hurdle, it goes into basically an empirical investigation. How close were your predictions to the actual ones that we observed? And we will do that for every single county. We will weight it by county population that we use. And for the 2017 and 2016, there are different weights, and the 2017 weight is higher than the 2016 weight.
Okay. How many submissions are you anticipating in a ballpark?
I don't think we're in a position to guess what your competition will be. So your guess is probably as good as ours.
Thank you. Are these acute care discharges only, all payers, VA included?
So I encourage folks to go to to look at the document of how the community statistics were created. In general, they are short-term acute care hospitals. They do not include federal hospitals such as the VA in general, but go to the document I suggested earlier for the exact way in which we have calculated the number of discharges.
Okay. Must the submission be made on behalf of an organization, or can individuals or groups of individuals participate in the challenge?
Individuals, groups, organization, as long as there is one, I would just characterize it as an entity. So you could be a single person, you could be an organization, you could submit on behalf of 5 researchers that you have together, and you could submit as one group. So any of those components are acceptable.
Are there restrictions on the platform and/or programming languages we use? For example, are we allowed to use cloud-based computing platforms?
Yes, you are allowed to use cloud-based computing platforms.
In the challenge Excel file, there are some discrepancies in the length of stay variable. Some values are displayed as 4.6, have the actual value of 4.599999046.3. Other variables have some displayed an actual value. What's the reason for this? Since I don't have the file in front of me, let me take a look at how that file is created, and we will post the answer on that one, because I'm a little bit handicapped for that. But thank you for bringing that to our attention. Okay. Does the hospital admission data represent a certain type of insured population, for example, Medicare, or the general population?
Again, I would suggest folks go back to the document I mentioned earlier about how the discharges were created, but in general, it is for all payers as long as they go to an acute short-term general community hospital.
Okay. Are the AHRQ data sets that are not open source available for this analysis? Or should
Can you repeat?
I'm sorry. Are the AHRQ data sets that are not open source available for this analysis, or should the models be based entirely on open source materials?
So it should be based on all materials that is publicly available. So, for instance, there are AHRQ data that requires a purchase for, say, a state-level databases. Because that involves a purchase, those databases are not permissible. So it has to be free, and it has to be publicly available.
What specific accuracy metric are you using to judge population weighted, MSE, MAE, etc.?
The criteria will be based on our calculations of the both the average length of stay and the number of discharges for all those counties based on the databases that AHRQ produces here. Your prediction is going to be compared to those numbers, and there will be a % difference that you have there. Again, we will weight it by county. So it's going to be the size of the county will matter, and that will have greater weight. And we will weight it based on 2017 predictions versus 2016 prediction, with a higher weight for the 2017 prediction, because we want these models to be able to forecast into the future.
Is there a performance metric that the judges wish to optimize? For example, F1 score versus precision?
No. The stated way in which we're going to evaluate it is where we are for this particular challenge.
What is the latest date that publicly available data be made public to be allowed for use in this challenge?
As long as you submit your application to AHRQ by June 28th, 2019, if something becomes available one day before and you're able to get it in, that is fine, but we need your submissions by June 28th, 2019.
Okay. Are statistical approaches preferred over black box approaches, or can either be used and be acceptable?
I think that we answered a version of that question. Black boxes, if we are not able to replicate it, then they will be disqualified.
Okay, that's all the questions I have right now.
Okay, I guess that concludes our Q&A. Thank you all for joining us in this webinar, and we look forward to receiving your application. Thank you.